Okay,
Yes,
starting the timer, and here is your question. Yes.
ma'am.
Yes. So if you have read and understood, kindly
Yes,
tell me what is your differential diagnosis, considering it to be a pathological surgical pathologist issue.
yes, ma'am. This gentleman with the long-standing history of smoking and with complaints of progressive dysphagia, initially to solids and then followed by liquids. My prime initial diagnosis would be, and also the weight loss and the GRD symptoms. I think first about malignancy.
Okay.
I would also think about other benign causes which can cause dysphagia as well. Chronic esophagitis or Barrett's esophagus, among other differentials.
Can you define GERD?
Good.
Yes.
It's it's basically reflux symptoms, mainly leading on to the stomach secretions to go on to the esophagus, causing metaplasia.
If you'll take a pathology,
Not sure about the
if you'll do
differential.
the if you'll do the biopsy at that time, how do you expect biopsy report to be?
It predisposes to metaplasia. Initially, there will be columnar metaplasia of squamous cells at Barrett's esophagus presentation.
Okay. Can you define different types of carcinoma? Or can you explain different types of ossifical carcinomas?
Different types of?
Ossifical carcinomas.
I didn't get that question. I'm sorry.
Okay. What should be the management of ossifical
Is this
carcinoma?
TNM classification, ma'am?
Yes, but then at different regions, you have to tell me
First,
in
we have to
different
grade the
types.
patient according to the.
Yes,
So
please.
basically, first TNM classification is based on the anatomical tumor size. So
Yes,
T0 is tumor, or TIS is tumor in situ, or high grade dysplasia. Then T1 would be where the tumor invades into the submucosa or muscularis mucosa, submucosa, and then T2 would be invasion into muscularis propria, and T3 would be invasion into adventitia, and T4A would be invasion into surrounding structures such as pleura, pericardium, and diaphragm, and T4B would be invasion into unresectable structures, aorta, vertebral body, and trachea.
yes.
Again, based on the nodal status, this is classified into three. It's N0 for zero. I mean, no lymph nodes, and one would be 1 to 3 lymph nodes, 1 to 2 lymph nodes, N2 would be 3 to 6 lymph nodes, and N3 would be more than 6 lymph nodes. And metastasis, again, M0 and M1. M1 is for metastasis, and M0 means no metastasis. Based on this classification, we can stage the tumor. There is another histological classification as well based on
Yes,
the grade of the tumor. That will be
yes.
well differentiated, moderately differentiated. G1 is well differentiated, G2 will be moderately differentiated, G3 is poorly differentiated, and G4 is undifferentiated. So based on this, we will stage the tumor based on the imaging, and also we should take biopsies from the tumor to get the histological diagnosis. And then we'll discuss the patient's case in AMDT and then plan accordingly for management.
Okay, can you
Early
please
stages of the malignancy can be, sorry,
yes,
ma'am, yeah.
please. Yes, please.
I said early stages of the malignancy can be planned for resection as a combined procedure, and late stages presenting with distant metastasis should be planned for palliative approach.
Okay, can you please tell me what are the etiological factors that lead to ossifical carcinoma?
Esophageal carcinoma,
Or what are
it
the
can,
risk factors?
risk factors, again, chronic smoking history, In this gentleman, presence of GERD, prolonged GERD can lead on
Chronic, yes.
to predisposition to adenocarcinoma in the lower third of the esophagus, and then uh,
Okay, if
prolonged metaplasia.
okay,
No, sorry, I'm not
which
sure.
test would you do to confirm your diagnosis?
For this, I would conduct a endoscopy with guided biopsy and immunohistochemistry of the cells from the biopsy.
What is the stain that you'll be using for immunohistochemistry?
Cytokeratin.
Good. Okay. If the pathology report comes back and it shows Barrett's esophagus, how would you define or what do you understand by the term Barrett's esophagus?
It's columnar metaplasia or squamous. Normal cells of the lining cells of the esophagus is by the squamous cells.
Yes.
In prolonged reflux and Barrett's esophagus, there will be metaplasia into columnar cells.
Considering esophagus, what is the most common type of carcinoma?
So
Adenocarcinoma. Okay.
adenocarcinoma.
Yes. Right. If a patient develops supraclavicular lymph node, enlargement of supraclavicular lymph node, what would you suspect? Or how would you go
It could
about
be
with
circulating
investigation?
enlarged left supraclavicular lymph node basically stands for virtuous nodes. It
Yes.
means that there is increased metastasis, and
Yes.
it's usually due to the thoracic duct emptying into the left junction between the subclavian and the internal jugular vein. And there's backflow of or there's obstruction of that junction, which causes a backlog and the enlargement of the lymph node.
Can you define metaplasia, please?
Metaplasia is a reversible change in the type of epithelium brought on by prolonged stimulus.
Okay. Uh, can you please tell me how many layers there are in esophagus?
There is
From
a mucosa,
outside to
submucosa,
inside,
then
yeah, inside
from
to outside.
outside to inside would be adventitia, then
Yes.
muscularis propria.
Yes.
And then there would be submucosa or muscularis, which has muscularis mucosa and the epithelium containing the basement membrane.
What is the normal esophageal lining?
Uh, Stratified squamous epithelium, non-keratinized.
Non-keratinized, yes. Okay, good. Can you please tell me if the same patient presents after few months with pleural effusion, then what might be the cause?
It could be the advancement of the tumor. That means the stage. Stage has gotten up, and it has gone from
Yes.
T1 to T4.
Yes.
Involvement of the pleura, and there could be lung metastasis. And I would
How
also think about obstruction of
how would
thoracic.
you confirm your diagnosis?
We can do aspiration cytology
Yes.
from the pleural fluid, and
Yes.
send it for checking for malignant cells and type of other cells.
What treatment
And also we
option
can do
would you
imaging.
offer this patient then?
In an advanced stage, like I said, we can only offer palliative treatment. For him, we can do periodic thoracocentesis, where we can remove excessive fluids in the lung cavity, and we can even place an indwelling pleural catheter.
How would you differentiate
And for his,
Barrett's esophagus from eclasia?
uh, based on the presentation, it will be different, ma'am, because
Yes.
eclasia will have initial dysphagia towards liquids, and sometimes liquid and solids alike. But whereas in
Yes.
Barrett's esophagus, there will be patient will have a long-standing history of reflux disease, more noticed during the evening or when aggravated when the patient is lying down. Prolonged history of reflux disease causing, which will be confirmed with biopsy from the endoscopy.
Long-term eclasia can lead to what type of esophageal carcinoma?
Squamous cell
Very good,
carcinoma.
yes. What treatment option can you offer then to the patient?
We'll have to stage and then plan for. We can esophagectomy, ma'am, transhiatal esophagectomy.
Yes, but there is a name for it.
Are you talking about Ivor Lewis procedure, ma'am?
Yes. Good, excellent. Anyone else want to give feedback? I really enjoyed. He even when he was thinking that he doesn't know, but he still knew everything. Excellent. He answered all the questions accordingly and had adequate, uh, too much adequate knowledge. Yes.
And the classification, is it the TNM itself, or were you asking about some other classification of esophageal
Yes,
carcinoma?
every aspect, like you told me, histological, and then this type of carcinoma where site on the basis of site, upper one third,
Oh,
middle or
upper
the
one
lower
third,
one
I
third.
didn't mention it.
Then you have to like consider all type of classification on the basis of. Then it's
Um,
like Barrett's, and then ecclesia can also lead. Then there are two different.
yes, ma'am. Upper one third will be more propensity for squamous cell carcinoma. Lower one third will be adenocarcinoma in view of Barrett's esophagus.
Yes. So
And yeah, other
I
classification,
thought
other data
I'll
point.
ask about the blood supply, but then I thought then that's a typical anatomy question. Cannot.
It's a long, slender tube. So upper
Yes.
aspect is by the inferior thyroid artery. Middle branches will be from the aortic branches, and the lower
Yes.
one third will be by the inferior phrenic
Yes.
branch of the aorta.
Inferior.
Uh, Esophageal branches of the inferior phrenic. I thought I'm allowed to read about that. Sorry.
Inferior when it traverses aorta, diaphragm.
Yes, ma'am. That's a lower aspect. In
Left
the in
gastric.
the okay, left gastric. Okay.
Yes. Okay, good. Thank you. Started the timer, and here is your question, please. Right. If you have read and understood, kindly tell me, if you do the histopathology, what would be the most common finding?
For histopathological of
Gallbladder.
pseudomembranous
Yes.
or gallbladder.
Gallbladder. Yes. Gallbladder.
Yes, it's female histopathology for the gallbladder.
Yes, please. In this
Yes,
case.
okay, you can pass this question for then.
Can you see this the last line? I thought you
Yeah,
read it. It wasn't too much. So if you do the
bladder,
histo, yes,
adenocarcinoma.
very
Yeah,
good. So you knew it.
yeah.
What is among adenocarcinoma? What is the most common one? Papillary. Can you tell me what is the most common cause in United Kingdom for gallbladder carcinoma?
Cholecystitis, chronic cholecystitis, and
And
cholelithiasis.
yes, okay. All right. Can you tell me what in case of gallbladder carcinoma, what is the most common site where it spreads?
Yeah, spread to the adjacent site of the liver, the segment 5. It could be
Yes.
common bile duct to the
Yes.
duodenum to the stomach.
Very good. Can you please tell me, considering it gallbladder, where would it spread first?
We will spread for the liver.
Yes, invasion to the liver. Okay. Can
Yeah,
you tell me, please, the lymphatic drainage of the gallbladder?
to the cystic lymph node to the
Very good.
yes,
Yes, please.
the cystic lymph node to the
Pericolidocal. Yes.
celiac lymph node
No,
leader.
pericolidocal nodes, and then to the regional node. Okay, you'll read this. Can you please tell me the risk factors for gallbladder carcinoma?
Is a female patient,
Yes.
obese,
Yes.
cholecystitis, gallstone also.
Gallstone. Okay.
Yeah,
And
it's genetic, familial.
yes, and
Um,
age.
yeah, old age.
Yes.
Yeah.
And gallbladder polyps, chronic
Yeah.
infection, chronic infection by S. typhus, etc. Okay, and obesity as well, and choledochal cyst. Okay. On this patient presented on fourth postoperative day, and she had surgical site infection. So, what is the most common organism you will find?
Staphylococcus aureus.
Okay, how would you suggest to manage that infection? Surgical
Yeah,
site.
if in this patient, if the general condition of patient unstable, I will stabilization the patient first as a CRIS protocol. If the patient is stable, I will treat the wound by open the wound debridement and central culture and sensitivity. Treated antibiotic according to the result.
Okay. This patient also presented with pseudomembranous colitis. What do you understand by that?
Pseudomembranous colitis is caused by prolonged use of antibiotic eradicated of the normal colonic flora and colonization and growth of Clostridium difficile, which secreted endotoxin to the destruction of the epithelial integrated cell and stimulated of inflammation.
What might be the cause leading to pseudomembranous colitis?
Clostridium difficile.
Yes, but if patient, how does the patient presents?
Presented with bloody diarrhea, abdominal
Bloody
pain.
diarrhea. So can you define the causes of bloody diarrhea?
Bloody diarrhea in this patient is pseudomembranous colitis, ischemic.
Define in, yes, according to infectious and non-infectious. Classify according
Yeah,
to like this, and then please tell me.
infectious is gastroenteritis.
Yes,
Non-infectious like ischemic colitis, also infectious pseudomembranous colitis,
yes.
ischemic colitis, and peptic ulcer would be the cause.
Okay, all right. You're telling me post-operative causes, not the one. Okay. If you'll do the in this patient, if you'll do the colonoscopy, how would the picture be? How do you expect?
You find island of yellow discoloration, oxidate,
Okay.
Irish protein
Yes.
substance with inflammation of the mucosa in between.
Okay. Can you please tell me the pathogenesis of pseudomembranous colitis?
Long use of antibiotic
Yes.
eradicated of the colonic flora, and this stimulated proliferation and colonization of Clostridium difficile, which secreted enterotoxin to degradation intercellular connection and stimulated inflammation and secretion of protein-rich fluid.
Okay. Just suppose this patient's wound does not respond to simple Staphylococcus aureus, and it becomes worse. It becomes wet and oozy and green liquid coming from out of it. And then what organism would you think?
The, yeah, it could be patient develop the necrotic fasciitis
Yes. Then
and
how would you go about with the antibiotic change or alternative?
antibiotic. Necrotic fasciitis is emergency case. You should
Yes,
treat it
yes,
according to the CRIS protocol,
yes,
stabilization of the patient, and prepare patient for urgent debridement,
yes.
and also consult infection control uh, team to about antibiotic and give him firstly broad spectrum antibiotic, then according to the culture and sensitivity.
Okay, what is the criteria that you have to consider
Yeah, there is
for it to be? Yes, there is one.
laboratory rate indicator of
Yes.
necrotic fasciitis
How much
criteria,
should it be?
more than 6.
Yes. So, how much would be the CRP?
150 CRP.
Yes, four times.
Uh, yeah, this is 4
Yes,
point.
yes. Oh, all right. Okay. Then who would you involve in the care of that patient at that time?
Infection control team, ICU, maybe patient need ICU, general surgeon or consultant surgeon who is responsible on the case, maybe plastic surgeon also.
Okay, and pathologist, speech pathologist might be involved. Okay, where would you manage this patient?
In ITU.
ITU. Good. Okay. And right. Would you consider skin grafting for this patient?
This is the final decision for plastic, but I don't think you need the skin graft.
If you consider skin grafting, would you consider it early or late?
Late, because infected.
But it says that early skin grafting can minimize fluid and protein loss. This is what you have to preserve.
This is a new for me, really.
Yes, right. How should this patient be monitored? Bell has gone, but one last question, please.
Monitoring with the patient.
Yes, in ITU you're managing, but how well, like how will you monitor the progress of this patient?
Clinically and paraclinically, clinically stop bloody diarrhea, decrease fever, general
Yes.
condition of the patient, consciousness, cardiac parameters, pulse, temperature, and urine output, input, and paraclinical by decrease inflammatory marker and
Yes.
improvement of if there is any complicated like systemic failure or renal function test, return to back to normal.
Good. And how would you investigate, or what test would you keep on repeating for this patient for your follow-up?
Blood glucose
Yes.
and acid base, electrolyte,
Yes, and yeah, blood test,
renal function test.
CRP, etc. All right, good, excellent.
Thank you.
In the beginning, you were little, yeah, barrier nursing.
Yeah, in the beginning, I don't understand what the question was. The result of histopathology. I didn't know from where, from
From
bowel
begin.
or from gallbladder or from where.
I thought you read the question, so I thought the gallbladder
Yeah.
carcinoma.
Yeah, I'm a little bit
So
confused.
that's all right. Sorry if I made you confused.
No. So I am sorry. No.
Okay, next.
About early skin graft is better than
Early
late.
graft is better than late. This is what the notes say. Started the timer, and here is your question.
What is the role in also sexual but it was of the and it's not
Right. So if you have read and understood, kindly considering it surgical pathology station. What is your provisional diagnosis?
My provisional diagnosis is that the patient is suffering from lymphoma,
Okay.
and additionally, he may be suffering from glandular fever, infectious mononucleosis, or tuberculosis.
Okay. How would you define lymphoma?
Lymphoma is a condition in which there is overproduction of lymphoid cells.
Can you classify it under carcinoma?
Yes, it's carcinoma because it is
irregular and un.
Carcinoma. Can you define carcinoma? From where carcinoma comes into existence, or from where it develops?
Carcinoma is the condition which develops from the epidermal layer,
Epithelial. Yes.
epithelial layer, while this lymphoma arises from the cell lines which are from the mesenchymal layer.
Okay. How would you define, or what are the different types of carcinoma?
Different types of carcinoma, man.
Yes.
Different
Benign,
types.
malignant. I thought you knew.
Okay.
Yes. Can you please tell me the differences between
Uh,
benign and malignant
yes.
cells?
Benign have well defined, while malignant lesions are not well defined. Benign
Yes.
lesions are slow growing, malignant lesions are fast growing. Benign lesions does not invade the surrounding structures, while malignant lesions invade into the surrounding tissues. And benign lesions have a well defined capsule, while malignant lesions do not have well defined capsule, and they are infiltrating into the adjacent organs. And benign lesions do not metastasize, while malignant do metastasize into surrounding tissue, into distant organs and tissues.
What treatment modalities can be offered according to the type of carcinoma?
In carcinoma, we can go with
Considering
excision
if
of the
it's
tumor.
benign or malignant. Please tell me like this.
If the patient is suffering from a benign tumor, and if it is causing him any discomfort, or we can go with excision of the tumor. But if it is not, then it can. But in case of malignant tumors, we'll first stage the patient, and after staging the patient, we'll go with the removal of the tumor and its lymphatic drainage. And additionally, if there is systemic disease, we'll go with chemotherapy or radiotherapy.
Okay, can you please tell me the mechanism of radiotherapy?
Radiotherapy has direct effects and indirect effects.
Very good.
In
Over
case over the rapidly dividing cells.
or the DNA? Yes, okay. How
Yes.
does it work?
In the indirect effect is that it damages the DNA of the rapidly dividing cells, and indirectly it leads to formation of free radicals, which damages
Yes,
the DNA.
yes.
So when there is damage to DNA, the damaged cells are not able to survive, and they lead to necrosis and apoptosis.
Okay. Three processes occurs as a result of it. Carcinogenesis, features the germ cells, teratogenesis, and then cell death. Okay, what is the SI unit which is used in radiotherapy?
What is the assay unit?
Yes, please.
Yes, in assay unit there are different units which we use for giving the patient dose of radiotherapy. We use the gray units, and
Yes.
for measuring his exposure to
Gray is
the
for absorption.
radiotherapy,
Yes. For dose, it's
we
sievert. Yes. And for
okay, dose
exposure,
is sievert, and for
yes.
exposure it is coulombs per kg.
Curie, yes. Okay, good. Considering that this patient has a nasopharyngeal carcinoma, can you please tell me the risk factors?
It is more common in males and more common in certain races. And
For
it is,
example,
for example, I think it's in China
yes,
and along this Singapore belt, Vietnam,
yes,
these countries. And additionally, it's more common in people taking more nitrosamines, more fish,
yes.
and if there is infection and genetic history.
Infection with which virus?
Epstein-Barr virus
Very good.
infection, genetic history, family history, and if the patient is using tobacco and alcohol abuse.
Okay, good. How would you confirm the diagnosis?
To confirm diagnosis, I will take his FNAC or excision biopsy of the lesion.
Can you please tell me the route of spread of nasopharyngeal carcinoma?
Nasopharyngeal carcinoma spreads. Uh, it
In
can spread
5
by blood spread.
directions. Yes, please. Go.
According to directions,
It
it
does
can
not
go
spread by blood.
anteriorly. And, sorry.
Lymphatic
For
spread and local invasion. Yes. How the local
but
spread takes
it
place?
spreads anteriorly into the nasal cavity and orbital invasion, superiorly into the sphenoid and convolution sinuses.
Yes.
Posteriorly, it spreads into the base of skull.
Yes.
Inferiorly, it spreads into the oropharynx.
Okay.
And it can also spread laterally into the lateral parapharyngeal spaces and in lateral pharyngeal spaces also.
Okay. Can you please tell me what are the common lymph node tumors that you can think of?
These are the lymphomas,
Yes.
leukemia, or metastatic tumors.
Yes. From other places.
Okay.
How would you investigate if there are metastases in the lymph nodes?
If there is metastasis, I will take biopsy of the lymph node, either FNAC or
Yes.
excision biopsy of the lymph node, and send for histopathological examination and by examination by immunohistochemistry. And additionally, I will look out for primary pathology by ultrasound, CT, or MRI.
Okay. Can you please tell me what you understand by the term sentinel biopsy?
Sentinel biopsy is the biopsy of the first draining lymph node of an area. In
Yes.
this, we give we inject the tissue with radio labeled material, and after that we see the radio labeled activity in the draining area. The first lymph node to drain, that is the sentinel lymph node,
Very good.
and for this we take biopsy.
Very good. This is most commonly used for which type of carcinomas?
For we
Esophageal?
use it for breast
Yes.
carcinomas
And some other as well.
and squamous cell carcinomas and other yes ma'am. Squamous cell
Very
carcinoma,
good.
breast carcinoma.
Excellent. It was tough,
Thank you.
but then you did it. Just once more you'll revise and it's done. Good.
Yes ma'am.
Yes, very good. Anyone else want to add?
Ma'am,
Yes, please.
treatment of nasopharyngeal carcinoma.
Yes, please. Tell.
About treatment of nasopharyngeal,
Yes, please.
it is that according to the location, but if it is removal of the primary tumor and in block neck
Actually,
dissection.
Dr. Kasif, I'll just mention you that the primary mode of treatment of nasopharyngeal carcinoma is external beam radiotherapy, means radiotherapy. Okay, because its anatomy, its anatomical site is such that we cannot go for the excision or any surgery. So it's a primary mode of treatment is radiotherapy. Along with, we can give chemotherapy also, either neoadjuvant, concurrent, or adjuvant immunotherapy.
Okay.
Chemotherapy. Yeah.
Okay. Thank
That's
you.
why I asked radiotherapy too much.
Yes.
Okay, ma'am. Thank you.
But then you said lymphoma, then you justified your answer as well, and my stem is very confusing. It can even be, yes, because it was bilateral cervical lymphadenopathy, so could have been even lymphoma. So very well you justified. But then I told you what I wanted to hear, so I just said, okay, imagine it was
Yes.
nasopharyngeal carcinoma.
Yes, you're right, ma'am.
So
It was difficult.
because of my mistake, I should have written the ethnicity. 43 years old, who? So then it would have been, maybe it would have given you some Caucasian or Mexican or Chinese, or then it would have given you hint. But the idea was to think and
Oh,
explore how do you, yes. WHO classification. Yes, Dr. Mohammed, please tell.
about the WHO classification,
Yes, of nasopharyngeal carcinoma.
I had it somewhere.
It is also called
Sorry.
grading or histological classification.
It is about some. I don't remember. Sorry.
Dr. Mohammed or Dr.
Dr.
Abhishek,
Mohammed
can
can
you?
tell us.
Yeah,
Yes, please tell.
WHO classification of nasopharyngeal carcinoma classified into three categories. Category 1 as defined will to moderate differentiated squamous or transitional cell carcinoma with keratin production. And category 2 non-keratinizing carcinoma and categorized undifferentiated carcinoma include lymphoepithelioma consist of malignant epithelial cells with lymphocytic infiltration.
Good, thank you. Now I think everything has been revised, right, on this topic. It should help, yes. Started the timer, and here is your question. Right. If you have read and understood, considering its surgical pathology station, what is your provisional diagnosis?
With the presentation, I think that it's a pleomorphic adenoma.
Okay. Can you tell me what you understand by the term pleomorphic?
Meaning different cell types. It could be a mixture of different epithelial cell type.
Okay, pleomorphic adenoma is what type of carcinoma or what type of tumor?
It's a benign tumor.
Yes. So, considering this, do you think there are any involvement of, or there any presence of malignancy?
No.
What are the clinical signs of malignancy?
So usually they can have facial nerve involvement, and then also the tumor size will be rapidly increasing, and also
Yes.
usually there's an invasion of the overlying structures, and
Yes.
then it will also be fixed as well. It's
How
immobile.
would you classify the tumors of parotid region?
I classify them under benign and then malignant.
Yes.
Benign, that's why you have the pleomorphic adenoma, like I said, and then you also have the Watten's tumor, and then you can also have the other benign tumors as well. Maybe papillomas too can be under it.
Okay,
And then,
good.
and then under the malignant ones, you have the adenocarcinomas. You could also have the mucoepidermoid carcinomas as well, and then adenocystic carcinomas.
Okay, is there any test that can help you differentiate between benign and malignant cells?
Yes, you can do a tissue biopsy.
Okay, or FNAC.
Yeah.
Okay, yes. Can you please tell me what are the difference between cytology and histology?
So cytology has to do with the study of the cells without doing any structural studies, while histology does the structures. So you could see the basement membrane, and then you'll be able to know whether it's invasive or not.
Is it possible to rule out malignancy during operation
No, you cannot rule it out.
with
during
frozen
operation.
section?
Yes, only frozen section you can know, but it's not like,
Okay, on FNAC, is it possible to rule out?
no, you cannot rule it out with FNAC. You have to do biopsy to rule it out.
You have to go back and read the notes. Okay, can you please tell me what you understand by the height sensitivity test?
I don't know about the high sensitivity test.
Okay, specificity test then. When would you
Okay,
yes.
I understand now what you're talking about, sensitivity. So when you talk about high sensitivity test,
Yes.
it has to do with the ability for you to identify, like to know, it's all about true positive, to know
Yes.
that whether disease is present. So when you talk about the high specificity test, it has to do with the true negative to identify that the disease is not present. That's actually it.
Okay, can you please tell me the risk factors of pleomorphic adenoma?
The risk factors are of pleomorphic would be maybe there's a obstruction of
Risk
the.
factors. What causes?
I can't remember.
Okay, you're telling me the complications. If you don't manage this patient, what are the likely complications that you can see?
So if you don't manage this, the tumor could actually change to malignant, and then there'll be malignant. There will be obstruction of the ducts, and then also the patient could present with facial nerve pulses.
When this patient has had this tumor for last 18 years, it was not bothering, but in the last 3 years, it suddenly started increasing in size. So what can you suspect? What changes might have happened
Maybe there is a
in the
malignant
tumor?
change.
So what are the clinical or what are the features of malignant cell?
Yeah, so in
term of
present
yes,
malignant cells or presentation?
yes,
Hello?
yes.
Presentation.
Presentation, or what are the features? How they change? What are the features? What
Yes.
changes occur from pathological point of view?
Pathological event. So you will see there will be pleomorphism usually, and then there will be increased mitosis, and then also usually the basement membrane of the would be breached as well.
Okay.
But that is for microscopically, but macroscopically, the tumor size will increase, and then it
And
will
then there'll
invade
be
the
invasion as well.
Yeah, vascular structures.
Okay, can you please differentiate between anaplesia?
Anaplasia and
Differentiation and anaplesia.
I think it has to do with the cells, but I cannot exactly remember.
What are the features of anaplastic cell?
So anaplastic cells, usually they can resemble the parent cells. Usually, they are well differentiated.
Yes, there are 5 points. More?
They don't invade the basement membrane, and then
They do invade.
they
Have, yes, malignant cells.
Okay.
Okay.
Yeah, that's what I remember. Pathology.
How would you differentiate? Now I've asked you all, and you need to revise. Okay. What should be the management of parotid tumors, considering it? Yes, it is pleomorphic adenoma.
So management, like you said, on pleomorphic adenoma is you have to excise it, excision.
Okay. And anything else?
Pain management.
Okay, if we can look at this image, can you please discuss image on the left hand side with the image on the right hand side, please? What is this arrow pointing at?
Yeah, that's a tumor. That's a pleomorphic. No, it's an adenoma. Pleomorphic adenoma. On the right. It's the same on the left. Well,
Okay. What is the difference?
between the two?
Yes, please. We are discussing.
One is bigger than the other one, but I think that's just because of the size, and then it's well defined.
Yes.
And then there is a, I think this one on the left, there is a hypodense image.
Okay.
The center. That's
Should
all I
the
can
should
say
the
about.
management be different if there was more penetration or more invasion of this tumor?
Yeah, I think so. They should, but I'm not sure.
Okay, I still have few seconds left, and I'm looking for more questions for you. Okay, bell went, but still, yes, please. Anyone want to add? Help doctor.
Ma'am, can I add something?
Yes, please. Yes, please.
Regarding a difference between benign and malignant cell, the microscopic features are mainly malignant cells are pleomorphic in difference in size and shape, and there
Yes.
is increased mitosis, loss of polarity, and
Yes.
abnormal mitotic figure,
Yes.
and there may be presence of malignant giant cell,
Yes.
and there is increased nuclear cytoplasmic ratio. In normal cell, there is nuclear cytoplasmic ratio usually 1:4 or 6, but in malignant cell there will be increase in size in the nucleus, so there is 1:1. So
Yes.
these are the microscopic feature in malignant cell, and these are not present in the usual normal cell. And another thing, the anaplasia means, I think there is lack of differentiation, means there is no resemblance between parent cell and the malignant cell.
How would you
This is
differentiate that from differentiated cell? How
it
would you
may,
differ
madam,
that? Yes.
in differentiation there is well differentiated, moderate, poorly, and
Very good.
anaplasia means there is loss of differentiation,
Very good.
so it has the poorest outcome, I think.
Very good. Very good. Yes, correct.
So madam,
Very good. Excellent. Yes. Anyone else want to add anything? It was excellent. Yes, Dr. Suman.
Yeah, actually, anaplasia, it is the loss of differentiation of a cell from its parent's group. That is the normal thing.
Yes.
That is loss of differentiation of a cell as from its parent group of cell. That is anaplasia, and it has also the same character like any malignant cell, like pleomorphism will be there, nucleocytoplasmic ratio will be increased. There will be also that mitosis will be increased mitosis. Like these are all the characters the anaplastic cell will show.
Yes. Good. Dr. Fatumata, there's one more question. I just find it out. If you're doing FNSC and your assistant gets needle injury, what would you do?
I have to report it, wash it out.
Yes, first wash it out.
Wash it out,
Encourage
yeah.
bleeding.
Yeah.
Encourage bleeding and then wash it out, and then
incident you have to report.
yes, report it, and then maybe counsel it for testing hepatitis B and C and HIV, and then discuss it with, if possible, microbiologist for post-exposure prophylaxis.
That's true.
Ma'am,
Yes.
just to add to that,
Yes, please.
usually if there is a needle stick, everything was right actually. So wash and then you report it.
Yes.
And then in the UK, so they will immediately send the patient to A&E if this is
Yes.
out of hours, or they will contact occupational health.
Yes.
And occupational health will do all of these blood tests of
Yes.
HIV, HP, hepatitis B, and hepatitis C.
Yes.
And then they will automatically start the person with the needle stick injury on post-exposure prophylaxis,
Yes.
whether or not the person has HIV load or not.
Good. Yes. Yes, Dr. Mohammed. You want to add something?
In treatment, surgical,
Yes.
if you discover this malignant, maybe needs chemo and radiotherapy.
Yes.
Yeah.
Yes. And if you discover in FNSE that there, or in biopsy, that there are lymphocytes or Langerhans giant cells, so then what should be the diagnosis?
Lymphocytes and that won't be TB.
Granuloma.
Yeah,
Yes.
granuloma maybe due to TB also.
But then if there are epithelioid cells in FNSE with brown cytoplasm, then what would be your diagnosis? Then it can be malignant melanoma because it's brown cytoplasm, you know.
Okay.
Yes.
Yeah.
Good. That was all I could find.
Ma'am,
on this
could you please
topic.
share the answer to the risk factors for pleomorphic adenoma? It's not
Yeah.
given, ma'am.
It's
Yeah.
given.
Yeah.
You have to read.
Okay.
The risk factor.
Dr. Mohammed, please tell them.
Okay. The risk factor for parotid tumor like radiation and smoker, especially in the wartime tumor,
Smoking, yes, first.
and the
No.
genetic and the environmental and the diet deficiency of the vitamin A and exposure to the nickel and cadmium and the silica and the infectious causes like Mombus, Epstein-Barr virus, and the chronic sialanditis and the recurrent inflammation lead to dysplasia and the carcinoma.
Good, it was good. Everyone enjoyed.
Ma'am, that is malignancy, but you asked specifically for pleomorphic adenoma. That's why I'm
Yes,
asking.
I asked for her. Yes, pleomorphic adenoma.
Is it for malignancy or?
Pleomorphic adenoma.
Pleomorphic adenoma.
Dr. Sridhar,
Yeah.
just a simple suggestion, like if any kind of malignancy, you can just divide this risk factor like age, sex, and race.
Yeah.
Okay.
Maybe.
Age more
And
than
then
70
add
years.
smoking and alcohol in addition.
Yeah,
I have to
Alcohol.
add it.
I'm just finishing it. Sex, like in case of men, it is more prevalent, and race, there are some ethnic variety also in this tumor. Positive family history, then alcohol and smoking, then radiation and infection. So it's like whenever the examiner asks you something that you don't know about this type of thing, you just go through in that way. That will help.
No. I mean, I understand that, Dr. Abhishek. I'm just saying,
Yeah.
ma'am asked specifically for pleomorphic adenoma. I was wondering if there's any
Oh,
specific
okay, I understand.
risk
And for
factor
this,
for that.
actually, smoking and radiation and the last section, these three is specific. And other than this, the age, sex, and race. That's
All
it.
right.
Yes.
Thank you.
Yeah.
Sorry, sometimes I am reading or extracting questions out from the recent published article.
Yeah,
So-
actually newer research also says that
Yes.
some genetic factors are also involved
present.
in pleomorphic involvement. And one
And-
viral infection that
Yeah.
what we call, I forgot the name actually.
Dr. Mohammed just mentioned you can hear recording and you'll know.
Okay. Yes.
Yes. Good. Excellent. I really enjoyed this one. I thought it's an easy topic, but then it really got into very good discussion. Good. Thank you, everyone. Here is your question. Right. If you've read and understood, considering its surgical pathology station, what is your provisional diagnosis?
My provisional diagnosis is most probably carcinoid syndrome, ma'am.
Carcinoid syndrome. Okay.
Am I right? Oh, sorry.
No. Troponin levels. When troponin levels ECG shows sinus rhythm, but then left ventricle height. There are you have to think. What is this single S2 S4 gallop? I have studied everything in it. There is carotid shudder. Okay, Dr. Siridat, come help Dr. Suman Kumar, Dr. Zaid, Dr. Kashif,
Yes, ma'am.
all.
This is aortic stenosis.
Very good. Why?
Okay, this is the aortic stenosis. Okay.
Yes, yes. Why? What are the causes of aortic stenosis?
Okay.
Would you like to continue or?
Yeah, I would like to.
Yes, please.
Aortic stenosis can be due to the rheumatic heart disease following rheumatic fever, or there can be due to the degenerative aortic stenosis, or any congenitally abnormal valve having calcification.
A patient presenting with rheumatic condition, how would the pathology be?
Pathology of rheumatic condition. Huh?
Yes.
You mean in pathological features, ma'am, right?
Yes, pathological features.
Okay,
or you can even tell me the clinical features. They are given, okay. Where first it's rheumatoid, so rheumatic inflammation has to be there. Then next, when there is inflammation, then there is adhesion as well, and then
there will be inflammation followed by adhesion and fibrosis.
Very
fibrosis good. As well as degeneration and then
calcification.
Finally calcification, and then there will be stenosis of the valve.
Very good. Okay. Yes. So if a patient with aortic stenosis suddenly dies, what might be the reason?
In case of aortic stenosis, there is decreased blood flow to the coronary arteries, which may cause the myocardial infarction. Or another cause is there may be the risk of what you call this aortic
dissection. Very good.
That can also cause the death.
Okay, so if the patient has aortic valve endocarditis, and after a while patient experiences weakness in the arm, what might be the reason?
There may be development of thrombosis and following embolism, which may be causing the this stroke. That is the brain. Yes, cerebrovascular or brain stroke. Yes.
Can you define thrombus?
Thrombus is the what we call this. What we call 1 minute, ma'am. There, if any constituents of blood forms the solid material while the blood is flowing, then it is called thrombus. And when the blood is static, then it is called clot. So thrombus is the solid material formed when the blood is flowing from the constituents of blood.
Okay, so can you please tell me which coagulation system will not be affected by warfarin?
Warfarin affects the mainly extrinsic pathway, so intrinsic pathway
will not be affected. Okay.
Yes.
So can you please help me to read this ECG?
Sorry, man, I'm very bad. This is still I'll try.
What should be the management?
Just 1 minute.
Okay.
Yeah. Actually, the lead 1 and lead 3, I think both are in opposite direction. Most probably it is showing the left ventricular hypertrophy and left ventricular stirring pattern.
And what type of rhythm can you see?
I can see it's, I think, normal rhythm.
Sinus rhythm.
Yeah, and normal sinus, yes, sinus rhythm.
And
the rate.
Any gallop anywhere in S4, S2, S4, anywhere? Can you see any difference? Is it sinus overall?
Actually, somebody can help me on that. I can.
Dr. Saeed, Dr. Kashif, Dr. Zaid, everyone, Dr. Sunday.
Ma'am, there will be, on examination, there will be pulses alterans, and
Yes.
on examination, there will be split paradoxical S2
Yes.
with a narrow pulse pressure and one more ejection systolic murmur in the aortic region.
Good.
No, in ECG.
On this ECG.
Well, in ECG, split S2 and left axis deviation. Sorry, left ventricular hypertrophy. Yeah, so left axis deviation
Left
and left
axis
ventricular
deviation is
hypertrophy.
there. Yes.
Yes, yes.
But any gallop rhythm you can see on S2,
QRS
S4
should be
leading.
split in this, but I'm not able to properly
Not
make out.
so. It's not so clear.
Gallop rhythm is like something to be heard. It's not found.
Yeah,
You
yeah,
cannot
it's split
see there.
S2.
Like the
No.
galloping of the horse.
Good.
That type of rhythm is
They
heard
were
on
not coming up with this
auscultation.
answer. You know, sometimes examiner ask you questions to see if
True,
you're
ma'am.
following or not.
We haven't done
Yes,
cardiac
please.
examination in how long?
You can actually see the split in the QRS complex in the AV. I think it's the
Yeah, I
third
was trying
lead.
to appreciate the split S2.
Yeah, so you can see that now.
Okay, what should be the management of aortic stenosis that you can offer this patient?
Okay. Management of aortic stenosis.
Yes.
So
It's always yes.
We always start with the investigation. We do the start with the complete history and examination, followed by the ECG, and also go for the echo and to see the all the ejection fraction and whether means it can be managed conservatively or patient has to be go surgically. We'll discuss the case with the multidisciplinary team if he needs any valve replacement.
Yes.
So we can go for the valve replacement.
So once you have done the valve replacement, metallic valve you have chosen, and then the patient develops infective endocarditis, what should be your next step?
If patient develops infective endocarditis, we have to remove that valve because it is a focus of it is actually septic focus because these they can form the biofilm on this artificial valve and it will be a septic focus. Also, due to this infection and there will be degeneration and valve will be destroyed.
Right.
So it has to be.
So if you have sent the valve and you have found out that there were microscopic branching hyphae on the removed metallic valve, so what would you suspect?
He will give me the suspect. I will suspect of any fungal infection.
So what are the types of fungal
there
infection
can be,
that can occur?
There can be candida. There can be candida aspergillus. There can be trichophyton or epidermophyton.
Very good.
Etc.
Yes. Okay. What more we can ask? Bell has gone. Thank you. Good. Anyone else want to add anything? Yes.
I was not expecting
it was also remaining from first day.
Okay.
And then it's good. You have practiced now. It's better when you'll be going for your exam. Once you'll read and it this topic will be brushed up for you. So it's good practice.
Actually, in my mind, first came aortic stenosis. But when you said these two stations left, I went through, then I saw that, oh, what can it be? I didn't saw that aortic stenosis is still left.
So from the first day,
I got misdirected from the list.
No, but you should not be. Always be present in your mind and then think, okay, what the clinical features are there, and answer accordingly.
Actually, it was directing me to the aortic stenosis, but I saw the list today, so I thought, what is this? So I
it's a long scenario. You can't.
I thought maybe
yeah.
carcinoid syndrome or something like that. But carcinoid syndrome, actually, there is hypotension or something, I think.
We'll find out. That station is also remaining.